Good morning. Welcome to the vascular session of the 48th Annual Convention and Scientific Meeting. I am honored and privileged enough to introduce to you our first speaker. She's actually a graduate of the University of Santo Tomas, and she's my batchmate. But she had her. She's also clinical. She's presently the clinical associate professor of the University of the Philippines College of Medicine PGH, head of the stroke service of the St. Luke's Medical Center, and she had her neurology training at the UPPGH. Among other things, let us welcome Dr. Cristina.
Good morning. Thank you for the kind introduction to be part of this convention. It's always a privilege for a neurologist to be part of a cardiologist convention. So let me talk to you about stroke prevention in high-risk patients. So some of my disclosures, I have been speaking and receiving some travel honorarium from different pharmaceutical companies. What do we know so far in stroke prevention in AF? The risk factors has been defined very clearly, and that's why we have that scoring system known as the CHADS-VASc. We know already that the treatment recommended is oral anticoagulation. In fact, the new recommendations now would say that there's really no role for any antiplatelet monotherapy in stroke prevention in AF. And trials on NOACs have been effective and safer than warfarin, and thus preferred over warfarin. Okay? So just to simplify things, because my topic is stroke prevention in high-risk AF, patients used to be classified as low, moderate, and high risk based on the ACCP classification. But because of the CHADS-VASc scoring, it has been simplified that anybody who does not have any of the comorbidities defined in the CHADS-VASc is defined as low risk, and thus does not really need any treatment. And all the rest would require oral anticoagulation from a CHADS-VASc 1 onwards. But new recommendations now somehow downgraded and made distinction as to the gender. Female was given a score of 1, and yet when they say your score is 1 because of only of a female gender, then you're considered as low risk and no treatment is recommended. So similarly, if you're a CHADS-VASc 2 and you're a female, that means you require at least 1 risk factor. And similarly, for a CHADS-VASc 3 for a female means you're a female plus 2 other risk factors. So now somehow downgrading the risk of a female gender. So I think what is more significant now is really how to use these new drugs, specifically when you're confronted with an acute AF-related stroke, particularly tackling 3 major issues. How do we initiate or resume oral anticoagulant following an acute ischemic stroke? Do we or should we initiate or resume oral anticoagulant following an intracerebral hemorrhage? And what to do in case of a stroke recurrence while patients are already on oral anticoagulant? So let's tackle the first topic. Initiate or resume oral anticoagulant following an acute ischemic stroke. Why is this a dilemma? Because this is this phase where in the acute stage, patients are very high risk for early recurrence. But this is also the risk where the hemorrhagic transformation is also at risk. And this is somehow that's very unique in AF or cardioembolic stroke. You have a thrombus or an embolus that's very soft and very friable, and the brain is subjected to reperfusion injury. So when you have recanalization, the vessels which have been ischemic also rupture. That's why you have almost very pathognomonic hemorrhagic conversion occurring in cardioembolic stroke. And if we look for evidences, unfortunately, you cannot look for evidences in the new trials. They specifically excluded randomizing patients at this time because of this risk of hemorrhagic transformation. So what do we use now? No? How do we now balance? We know that patients may have a recurrence, and it's up to about 5 to 8% in 2 weeks, and that's not negligible. That's very high, and can be as high as 20% in patients who have thrombus, valvular heart disease, rheumatic heart disease, and CHF. At the same time, hemorrhagic transformation is very common, usually within the first 2 weeks, and MRI, if detected by MRI, which is a very sensitive test for bleeding, it can be detected in as high as 70% of patients. And again, certain populations are at high risk, more severe stroke, and patients with large infarct and uncontrolled diabetes and hypertension, which means prior to the stroke. So if we look at the guidelines, AHA would say most patients, you can anticoagulate early within the first 2 weeks. And the only time you will delay oral anticoagulation, let me just highlight oral. No? They're not recommending bridging or low molecular weight heparins. So you delay oral anticoagulation if you deem that person is high risk for hemorrhagic conversion. So how do we now balance the decision? So this is now putting all things in. It's now, timing will be dependent on the infarct size and clinical severity using the NIHS score. So just to simplify things, if a patient has TIA, which means symptoms have been transient, and by imaging there's no permanent damage, then you can start anticoagulation early as soon as imaging and some of the blood tests has ruled out that there's no contraindication to start anticoagulation. The other extreme, patients who have very large stroke, hemispherical stroke, severe strokes, would require at least 2 weeks of waiting time before you consider anticoagulation. And anything in between, mild to moderate stroke patients, would require a period from 3 days to up to 14 days. And Diner is a neurologist, a European neurologist, made it simple by coining the rule 1-3-6-12. So just to say if it's mild or TIA, it's 1, 3, 6, it's just to multiply, and 12, 1, 3, 6, 12 rule. But what is important here is highlighting using of the imaging also to help you make the decision. Okay? So this is some of imaging showing you that this is a normal CT scan, this is probably a small infarct, this is categorized as a moderate size infarct, and if you have involvement of the main trunk, that's a large infarct. Remember, hemorrhagic conversion would occur at the area of the infarction. So you don't really worry about this converting, kasi very small siya. And always, when you do look at the imaging, it's not also only look at the infarct size, but look as well as to the degree of hemorrhagic conversion. So these are different types of hemorrhagic conversion, and this is the worst type, known as parenchymal hemorrhage type 2, when there is significant mass effect. Here you see some mass effect already obliterating the ventricle, but it's not causing significant shift. So it's a PH type 1. Okay? Second question, how or should we initiate or resume oral anticoagulant following an ICH? So the dilemma, should we start or give no treatment at all? Should we give an antiplatelet, or should we just go to a procedure and do not give any antithrombotic? And secondly, when to start oral anticoagulant if we deem that we can resume it? And third, is there really a modification of oral anticoagulant effect depending on hemorrhage location? So what do we see in terms of data? This is a study that it looks observationally into patients who had bleeding secondary to oral anticoagulant, and there was a decision to not start any treatment versus start an antiplatelet versus start an oral anticoagulant. We see that in the group that were treated with oral anticoagulant, meaning they were resumed, it was resumed, you see that the ischemic stroke, mortality, and systemic embolism was significantly reduced compared to no treatment, and bleeding was not significantly increased. If you compare this to the group that was treated with an antiplatelet, it did not afford any benefit with also increased bleeding risk. So just to say, there's no point. It's like when you give an antiplatelet, it's like not giving any treatment at all. Okay, so this is very new, just out. And this is a meta-analysis or a systematic review of all observational trials that looked again at resuming an anticoagulant among patients who had intracerebral hemorrhage. And you see all observational studies, this is the one I quoted earlier, showed that it was, the forest plot was in favor of resuming because there was significant reduction in arterial thromboembolism. And we looked at the risk of recurrent ICH, it was not significantly increased. Okay? But these are all observational studies, and there are currently 4 ongoing trials now on this subject. So we probably will have to wait in a few more years to get data on RCTs. Okay? So this may be a guide now. You may start oral anticoagulation provided that the cause of the bleeding is treatable. It's trauma-related, subdural hematoma that has been evacuated, if it's aneurysm that has been secured already. If we're dealing with the hypertensive bleed located deep in the basal ganglia, patient with well-controlled hypertension, there minimal white matter lesion, and the patient is considered to be high risk for recurrent stroke because of high CHA2DS2-VASc score. And timing is recommended to be 4 to 8 weeks following your intracerebral hemorrhage. When is oral anticoagulant not recommended to be resumed or initiated anymore? If the cause of ICH cannot be treated. For example, you have an aneurysm that cannot be secured. It's a giant aneurysm that cannot be secured or coiled. If you have a cortical or lobar ICH, I will explain that later on. If you have a severe intracranial hemorrhage and you're left with a severely debilitated patient, probably not start oral anticoagulant anymore. Uncontrolled hypertension, multiple microbleeds, chronic alcohol abuse, when ICH has occurred with adequate or underdose of an oral anticoagulant, and if the patient would require dual antiplatelet, that patients who had undergone PCI. Okay, remember, the Hasbled scoring now is recommended not to contradict oral anticoagulant use, but to look for modifiable risk factors. So if you look at the Hasbled scoring, there are a lot of things here that are modifiable. So control the hypertension, if patients is on warfarin, control your INR, and probably make limit or avoid prescription of drugs that would increase bleeding risk like NSAIDs, steroids, antiplatelets, and limit alcohol use. Abnormal renal or liver function is a potentially modifiable risk factor for bleeding provided the patient is not in CKD or liver cirrhosis. So this is important to identify and modify these modifiable risk factors. Okay? Just a small short note on location of hemorrhage. When we say deep hemorrhage, that's located in the basal ganglia or in the brainstem, your pons, your cerebellum, versus one that's located in the cortical areas like your frontal, parietal, temporal, and occipital lobe. When they looked at the benefit of giving an anticoagulant in patients with deep ICH, compared to those with lobar ICH, you see that the numbers are the same, so you get the same benefit. But you look at the risk of new ICH, it was significantly increased in patients with lobar ICH, negating any benefit from treatment. And it is because of the pathophysiology. When you have lobar ICH, it's often due to amyloid angiopathy, especially in elderly patients. Amyloid deposition causes the wall of the vessels to weaken, causing frequent spontaneous bleeding. Okay? Okay? And if bleeding has occurred secondary to warfarin, then we have probably the better option of using the NOACs. Individual trials and even by meta-analysis and systematic review, they would all consistently show better safety profile, specifically in the rates of intracerebral hemorrhage. So less with the NOACs or the DOACs. Okay? Last, what to do in case of a stroke recurrence while the patient's already oral anticoagulant. So first is check if stroke has occurred under adequate anticoagulation. Check the dose, check adherence, if warfarin time in therapeutic range, and optimize. Okay? And if this has occurred, no, that everything has been assured, then probably switching to another oral anticoagulant may be considered. But bear in mind that you might miss out a significant diagnosis, which means do not neglect looking at the arterial bend in patients with AF. You might actually have a patient with concomitant carotid disease, like 70% stenosis and an AF. And the recommendation is address that carotid stenosis by endarterectomy, not stenting, because stenting would require dual antiplatelet therapy. So surgery, then anticoagulate. Okay? Key points. Except for low-risk patients, as CHADS-VAS 0, oral anticoagulants are recommended for stroke prevention in AF. Guidance on the management of acute AF-related strokes are mostly based on consensus and observational studies. In patients with acute ischemic stroke, start oral anticoagulant based on empiric recommendation, which is individualized. Weigh the risk of hemorrhagic transformation versus risk of early recurrence. What to do during that waiting period, the guideline would say you can give an antiplatelet during that time period. In patients with ICH, carefully select patients to initiate oral anticoagulant. Timing of initiation would be after 4 to 8 weeks. Patients with lobar ICH or secondary to amyloid angiopathy are best managed without oral anticoagulant. And it's reasonable to consider NOACs in patients who suffer from warfarin-related ICH. So we wait for the new trials on this topic, which will be out probably in the next few years. Thank you very much.
Good morning. Our next speaker will be, she is a chairman of a section of cardiology and the head of the ICU Services Department of Medicine, Cebu Veles General Hospital. She is also the head non-invasive cardiovascular laboratory at the Vicente Soto Memorial Medical Center, also in Cebu. And she is a clinical professor at Cebu Institute of Medicine. And she is the head critical care unit of the University of Cebu Medical Center. And she has been the past president of the Central and Eastern Visayas chapter of the Philippine College of Physicians. And she is also the past vice president of the local chapter of the Philippine Heart Association in Cebu. And she had her research fellowship in peripheral vascular medicine and biology at the Heart Institute, St. Luke's Medical Center, Quezon City. She is one of my mentors in Cebu, and she will be lecturing how to change the style of the living of patients with chronic venous diseases. She is no other than Dr. Celine Aquino.
Good morning. This is a terrible topic, and I realize that I'm being given this topic because nobody else would accept it, but good morning anyway. Now, living with chronic illness is always challenging, and when the available interventions are few and successful treatment is inconsistent, sometimes hoping is a matter of modifying lifestyle and just living with the disease. I have no pharmaceutical interests or ongoing research in phlebotropics or the compression devices, and my objective will be to scrutinize the lifestyle changes that are evidence-based or otherwise that are touted to solve the problem of chronic venous insufficiency and living with it. And we'll reach that objective following this outline. Now, chronic venous disorder is a heterogeneous term, and it refers to all venous abnormalities whether or not they are symptomatic. And while venous thrombosis is dramatic, it is an acute problem, and it is chronic venous insufficiency that will present long-term. Understanding how it happens will make an impact on our management and the success thereof. So why does this happen? Well, it ain't no act of God. It begins with a genetic predisposition and the environmental factors that lead to the close adhesion of leukocyte and endothelium. So the interaction of leukocyte and endothelium will lead to the phenomenon of chronic inflammation. And this in turn will lead to remodeling of the venous valves and the veins and the walls, and thus will result in venous hypertension. Now, it happens that the muscular contraction of the calf during walking is what brings the pressure down. As the valves, however, become incompetent, then the problem of venous hypertension will be aggravated by the failure of the venous pump, of the calf pump. So this musculoskeletal pump that fails allows the veins to fill more quickly, and they dilate, they become varicose. So therefore, the ankle foot pump, which is so efficiently capable of returning up to 20% of the blood back to the heart with each contraction, becomes ineffective when we have venous insufficiency. If left to itself, it is a progressive disorder. Simple mechanics will ensure that venous hypertension will inevitably lead to the trophic skin changes, and these changes will themselves become self-perpetuating, and they will result in a vicious cycle that eventually leads back to the venous reflux and the venous hypertension. So it's not going to end. Today's management is a complex interplay between the pharmacologic and non-pharmacologic interventions, with our base as the compression or elastic support and the vein removal or repair as the final solution. But this morning I'm going to talk about lifestyle modification. Does it work? Now, today the internet is filled with miraculous interventions that can do away with venous disorders with a cream, etc. And they will guarantee that your legs will be that of Miss Universe. So we're going to look at these interventions and see if they do work. And to answer that question, it will be reasonable for us to refer to our pathophysiology and natural history. And like all diseases, we begin with addressing the risk factors. So let's ask a few questions. Is having varicosities written in the stars? Unfortunately, it may be. The most consistent risk factors are age, gender, family history, and connective tissue or ligamentous laxity. Unfortunately, these are non-modifiable. However, identifying that we do have these non-modifiable risk factors will mean that we can have an early start of preventive measures, and more of that later. But there are modifiable risk factors. Now, being female is a risk factor, and it's non-modifiable. It means having double X chromosome. Regardless of what the phenotype is, the double X chromosome is what makes a person female. However, the number of pregnancies is directly related to the risk, and this risk factor is modified. So is smoking, so is prolonged standing and sitting, as well as central adiposity. All of these are modifiable risk factors, and therefore they are amenable to intervention. Seem to be self-explanatory. Can weight be an important? How important is obesity? Well, is it important at all? Well, yes, it is important, because adipose tissue does not offer support for the veins. So an excess of adipose tissue will mean there is less support for the veins, so that they are able to dilate more and become more incompetent. Obesity itself will act as an impediment to the venous return and will promote venous hypertension. Sadly, weight has a greater effect on venous insufficiency progression and incidence in women than it does in men. So among the lifestyle changes that we must impose, the maintenance of ideal body weight ranks very, very high. When we stand for long periods of time, we need to understand what happens. Walking in humans is a remarkable phenomenon. The alternating plantar flexion and dorsiflexion of the foot. makes the calf muscle act as a pump to push the blood upward and back to the heart. So if we inactivate this pump, then we develop stasis. And when we stasis, it means that standing alone is not the problem. The problem is immobilization. So that if we're going to be prolonged standing in our occupation, the leg stimulus will be, symptoms will be worsened by any kind of stasis, and therefore we can shift from one leg to the other. We can stand or sit up and down in a footstool, or even going up and down on a tiptoes is going to be enough, and they will be useful in occupations that provide prolonged standing. What about high heels? I have to give up high heels? Just kill me now. We see therefore that the constant plantar flexion that is imposed by high heels is a non-physiologic phenomenon, and that will impair the ankle pump and promote the stasis of blood, and therefore promote venous insufficiency. Therefore, the meaning of sensible shoes is low or no heels. It promotes the activity of the ankle pump during ambulation. But is there really a need to be sensible all the time? Actually, there are also some recommendations that we can alternate shoe height, and going barefoot occasionally is actually promoted because it makes the ankle move more, it demands more from the calf pump and the foot. However, a judicious use of high heels can be part of their lifestyle, because lifestyle is also quality of life. If high heels make you happy and you're willing to pay the price, then why shouldn't you wear high heels? What about, I don't stand at all, but I sit at the desk job? If we're sitting, immobilization is immobilization. If we're not moving, the veins will feel the crushing pressure. And the venous hypertension that develops here is the same as that which develops with prolonged standing. We activate the calf pump when we're sitting for longer than 30 minutes at a time. So the calf pump just means dorsiflexion, plantar flexion of the foot. And there was a useful exercise that was in one of the airplanes that go internationally, and it said, pretend to write the letters of the alphabet with your feet once every 15 to 20 minutes, and it is a useful way of activating the dorsal pump. So immobilization is the enemy. We have to keep that calf pump activated. Are there other types of immobilization that put us at risk? For example, when we are in a cast. After injury, any situation that predisposes to phlebitis and subsequent chronic venous insufficiency, plus the immobilization imposed by a cast, are risk factors for the development of chronic venous insufficiency. And in this case, even just dorsiflexion will be helpful. The limited movement allowed can be done to prevent the venous insufficiency cascade from starting. So movements up and down, movements up and down. The first event in the development of venous hypertension is the contact between endothelial wall and the leukocyte. And this contact is maximized with blood stasis. So again, immobilization is the enemy. That means we should exercise all the time. Now, the muscle contraction that leads to a fall in venous insufficiency, venous pressure, is going to lead to a reduction in the stasis, and therefore exercise is the mainstay of lifestyle change. However, we have to remember that in CVI, the drop in pressure is attenuated because of the venous dysfunction, and therefore the means of preventing blood from pooling in the venous in the lower extremities is attenuated. And this brings us to compression. So if we are going to be exercising when we have venous insufficiency, compression should be part of our lifestyle also. Okay. But when venous hypertension develops and it begins the ruinous cycle that ends in trophic soft tissue changes, we need to understand how we can intervene there too. How important is venous hypertension? And how does leg elevation help? Does it help at all? Yes, it does. But we keep the legs at or above the level of the heart. And we don't have to do it excessively. There's really no need. Because consider the giraffe. In a case of a giraffe, they're very tall. And the average pressure in the vein is approximately 200 millimeters mercury. But I've never seen, and there's never been a giraffe with varicose veins. And that is because they do have a built-in fibrous tissue that encompasses around their veins. And this creates a built-in compression stocking. So it means that if we prevent the increased venous pressure from causing extravascular fluid extravasation and the consequent inflammation, there will be no varicose veins. So it's not just hypertension per se. We've got to prevent the effects of the hypertension. So, How does leg elevation help? It will augment venous flow by gravity. It will lower the venous pressure, ameliorate edema. But there's no need to go overboard when we are sitting. It should be above the levels of the thigh. So hence the footstool. Or if we are lying down at the level of the heart. So there are those who do it in extremity and there is actually no need. So now we go to compression. When we start our patients on compression, we should always discuss with them and examine our therapeutic plans. We need to ask ourselves, are our expectations logical? The compression does relieve the symptoms and prevents a progression of the CVI stage to the final ulceration. But to actually remove the varicose vein, this takes mechanical means. And therefore, we have to tell the patient that the compression is not going to take away your varicose vein. It's going to reduce, probably, their appearance, but it's not going to take it away. It's going to improve the symptoms, definitely. It's based on Pascal's law that states that pressure applied to an enclosed system and the fluid, which are incompressible, will be distributed evenly. So that if we apply pressure to the leg, and the leg has no other way to let the pressure out, it's going to push it all the way back up to the heart. But we also have to remember that compression therapy is not a cure-all. The data supporting the use of compression is certainly there, but the evidence is not overwhelming. And in fact, it's not actually very nice to see. However, we don't have very much else. So we do impose compression. The second point is we have to be sure that we're using the compression right. Have you ever tried a compression stocking? I think you should try. I think everyone who prescribes it should try. It's way difficult to wear. It's way difficult to take off. And when you're wearing it and sweat, the rubber interacts, the garter, the rubber in the stocking interacts with the sweat and causes a terrible itch that has to be resolved by removing it and scratching. When we wear it, we start at the foot. It seems to be a no-brainer, no? But you'd be surprised at the number of people who try to get it up the thigh first. So the stocking is put into the foot, and you just work it up slowly and make sure that it's fully tight. That means that if you can pick your stocking off your leg, it's not fitting right. It means that you have little wrinkles along the way. It doesn't fit right either. So you want to avoid that. The stocking has to look smooth. And if it is not looking smooth, it is suboptimal. Are we using the right kind of stockings? The research indicated that the digressive stocking, which has heavy pressure at the bottom and lesser at the top, was effective. And this is so. It's based on the principle that if you increase the pressure at the bottom, then the blood has to go by capillary action up. But the Pascal's laws say that whatever the pressure is going to be equal throughout the whole system. So we have what is known as progressive stocking, where the compression is highest at the calf. So the compression stocking, which is digressive, has higher pressure at the bottom and then gradually decreases to the top. But in the case of a digressive stocking, it's higher in the calf. And this is an acknowledgement of the importance of the calf mechanism for the ankle pump. So that augmenting the pressure at the ankle, at the calf, will help the blood by moving up by augmenting the ankle pump. And the studies actually show that it is a better way, so that this might be something that will create a paradigm shift. We see here that the ideas about compression has changed over the years. What we know now is that compression is not affected by body position. So the horizontal, prone, standing position will equally affect deep veins. So therefore, if the patient's venous symptoms are severe, wearing them horizontally when you are lying down could still be helpful. First, that the highest pressures are no longer best at the ankle, they are best at the calf to help augment the ankle pump. And then, the higher the pressure doesn't mean the better. So actually, like makeup, less, maybe more. So the lower pressure may be more effective than the higher pressure. And also, better for the compliance of the patient. And it used to be that if the patient had a concomitant arterial problem, we couldn't do compression. Actually, this is also proven to be wrong. Up to 40 millimeters pressure can actually improve arterial flow. Hence, the use of impedance pressure, intermittent pressure in the case of arterial ulcers. So now it's equally effective in arterial and venous ulcers. So let me address the novel interventions first. Now we have the possible genetic connection. And fortunately, recently with the advent of personalized genomic medicine, they have identified the gene for varicose vein or venous valve failure. This is the FOXC2. And yesterday we had a fine cardiovascular genome lecture. And now we have here the identification of the genome of the gene for venous insufficiency. It's found in chromosome 16. And the identification can be useful with the advent of personalized genomic medicine, that even as young as in children who carry the gene, we will already impose our early lifestyle change, maintenance of adequate weight, compression, and exercise. Now, there's a lot of talk on the internet about myofascial release, and many people think myofascial release is just pressure, massage. However, myofascial release emphasizes it makes use of deep sustained pressure on dry skin. That means that if you're going to use lotion or oil, that's something else. So it's not that. And the principle is that it's supposed to break down restricted tissue. I don't really know what it means. However, there are some papers that state that it has a possible use in the CVI that develops postmenopausal. So myofascial release is deep sustained pressure on dry skin. And it is proven by a couple of studies to be useful in women, postmenopausal women who have venous insufficiency. What about true massage? Fact is that massage just induces a feeling of well-being, and it actually doesn't do anything for venous insufficiency or the varicose veins. It's rather part of the holistic approach that will improve cardiovascular symptoms, and especially the symptoms of the cardiovascular chronic venous insufficiency. Is there any point in changing the sleeping position? Now, there are these that are sold on the market. I saw a huge market on these, and apparently they are sold. And you know what these are called? They're called doctor's lounge. So you see, it's marketing, because it's called a doctor's lounge pillow. So because of that, the layman will say, why the doctors use it? So this one is actually called a doctor's lounge pillow, and it's selling retail for about $35. So unless the legs are very edematous or the varicose veins very large, the evidence says we don't need to elevate the leg more than slight. That means less than 5. So we don't need to do this to sleep. Well, unless you're doing something else maybe, but for sleep it's not necessary. There's also a lot on the internet about magical topical medicines. So the magical topical medicines can be all of these. Horse chestnut is very high, and then other things. And there's also the traditional Chinese medications. So what we do know is they are going to attack at the inflammatory level. So all these claims about disappearing, which they all do, they say that it makes it disappear. There is no physiologic basis for that. Now, there is no randomized controlled trial, not even a trial at all. These are all just testimonies when I look through them. And although they're advocated by the complementary therapy brethren, the fact is that at best they are only for symptom relief. So, in summary, therefore, as a complete evaluation accompanies the consultation for venous insufficiency and venous disorders, before we start doing lifestyle change and intervening, we first have to rule out the important stuff like cor pulmonale, carcinomatosis, Eisenmenger syndrome, portal hypertension, because chronic venous insufficiency might be the tip of the iceberg that is a very severe disease at the bottom. And if we rule out the underlying problems, there may be strong evidence for genetic basis. However, the fact is that the pressures that are involved in sitting and standing mean that our venous disease is a lifestyle change, and it will particularly be important in our management. As yet, there are no therapies for deep venous insufficiency that are proven to actually cure. Lifestyle change can delay the onset and alter the course of the disease, but it cannot cure. And in the end, it's so much harder to treat CVI and varicose disease. It's so much more effective therapeutically and cost-wise to simply prevent them. Our management should include a frank discussion with our patients on why the disease develops and what can reasonably be expected in the way of improvement. After all, our chronic venous insufficiency patients have to live with their disease. And if chronic venous insufficiency and varicose veins are inevitable for some, suffering for it becomes optional. It is possible to live with them. Thank you for your attention.
Thank you, Doctora, for that extensive lecture. Now, from from changing the lifestyle of patients with chronic venous disease, we now go to optimal timing of carotid endarterectomy versus carotid artery stenting following an index event. What are the current guidelines? Now, to speak about that is a thoracic and cardiovascular surgeon from the Philippine Heart Center. He had his endovascular clinical and research fellowship at the Arizona Heart Institute and Hospital at Phoenix, Arizona. He is presently the head of the Peripheral Vascular and endovascular section of the Philippine Heart Center and chairman of the OR Management Committee of the Philippine Heart Center. Welcome, Dr. Edgar Tuazon.
Thank you very much for that introduction. Okay, so good morning, everyone. If you look at the topic for today, it's a very interesting topic. Actually, for those of you who are interested in carotid artery disease, for the longest time, we've always talked about which actual modality is better, comparing open surgery to that of carotid artery stenting. But today's topic would focus more on the current guidelines on the timing of carotid revascularization, whether it be on open carotid endarterectomy or carotid artery stenting after stroke. I have nothing to disclose. And the reason for this thing to have a closer look is because there is virtually an absence of high-level evidence from studies directly comparing the outcomes among the treatment groups. And subsequent pooled analysis of these large randomized trials included only symptomatic patients in stable neurologic condition and did not assign treatment by timing, nor did it consider timing in detail, nor did it include sufficiently patients receiving surgery within 48 hours from symptoms. As well as there is a lack of standardized definition of for urgent timing and for unstable neurologic conditions such as stroke in evolution and crescendo TIA further confounded the risk estimation of early carotid revascularization in selected patient subgroups. And finally, the lack of accurate natural history on data on outcomes in untreated patients presenting with comparable degrees of neurologic stability after index event does not allow meaningful conclusions on the benefit or lack thereof derived from revascularization, especially in the early less than 48 hours time window. So all of these guidelines actually would stem from data derived from studies published. And if you look at this paper actually, which I dug up way back in 1969, was published, and they reported a mortality rate of 42% out of 50 patients, almost half of those patients who underwent carotid endarterectomy after a symptomatic carotid artery disease or a recent symptomatic carotid artery disease, and which led them basically to suggest that operation should be deferred for at least a minimum of 6 to 7 days, and some believe that surgery should be even postponed for as long as 6 weeks to 3 months. And hence, during this time, the guidelines, or at least most of the prevailing thought, would be to defer surgery for a period of 4 to 6 weeks post stroke. No? And even another paper, which was in 1985, and they showed that those patients who were operated within week 3 or week 5, had a higher chance of getting a stroke after undergoing carotid revascularization, and even pegged at 18.5% of incidence of morbidity. So this led them to finally conclude that it is safer to postpone carotid endarterectomy for 5 weeks post-stroke. This was in the mid-80s, no? And it wasn't until the paper which came out in early 2000 actually, wherein they actually did show, strangely enough, for 0 to 2 weeks, if you look at the chart on the far left on the first column, they showed an absolute risk reduction of 30.2% for those carotid stenosis of more than 70%, and 14.8% reduction, absolute risk reduction for those lesions with 50 to 69% in the period from 0 to 2 weeks post-stroke. And as you go further, meaning as you delay the surgery, then you lose that benefit. As you can see, the risk reductions decreases correspondingly. And hence in 2006, the AHA and as well as the American Stroke Association in the prevention of stroke suggested, or at least gave a recommendation that carotid endarterectomy is indicated for patients with TIA or stroke, and surgery within 2 weeks is suggested. And among patients with symptomatic severe stenosis, more than 70% in whom the stenosis is difficult to access surgically, medical conditions are present that greatly increase the risk of surgery, or other specific circumstances exist, such as radiation-induced stenosis or restenosis after CEA or carotid endarterectomy. Carotid artery stenting is not inferior to endarterectomy and may be considered. This was in 2006. Carotid artery stenting is reasonable when performed by operators with established peri-procedural morbidity and mortality rates of 4 to 6%, similar to those observed in trials of CEA and carotid artery stenting. Then as we move forward in 2011, again, more or less similar recommendations were made in as far as AHA guidelines, now this time involving several societies to come up with these guidelines. And again, intervention within 2 weeks of the index event is reasonable rather than delaying surgery, as the risk for developing ipsilateral stroke post let's say the index event stroke is normally pegged about 9 to 13%. So again, a recommendation within 2 weeks. And it is reasonable to choose carotid endarterectomy over that of stenting when revascularization is indicated in older patients, specifically more than 70 years of age, and particularly when arterial pathoanatomy is unfavorable for endovascular intervention, such as if you have a preoperative CT scan showing a rather diffuse atherosclerotic aortic arch, and this would prove to be increased in terms of morbidity as you negotiate your wires up through the carotid arteries. And it is reasonable to choose carotid artery stenting over that of carotid endarterectomy when revascularization is indicated in patients with hostile neck anatomy, which are unfavorable for arterial surgery. Let's say let's say you're doing a redo carotid endarterectomy, or the bifurcation for carotids is way up in the angle of the jaw, and as well as post-radiation patients who will undergo CA. These are all adverse neck anatomy, which you may want to choose carotid stenting instead. And as far as for European guidelines is concerned, in 2011 when they posted this, in symptomatic patients with indications for revascularization, procedure should be performed as soon as possible, optimally within 2 weeks of onset symptoms. So for the North American as well as the European guidelines, pretty much consistent with each other, the window period of 2 weeks post-stroke, to do any carotid intervention. And in symptomatic patients at high surgical risk requiring revascularization, again, stenting may be considered as an alternative to open surgery. And likewise, in symptomatic patients requiring carotid revascularization, carotid artery stenting may be considered as an alternative to carotid endarterectomy in high volume centers with documented death or stroke rate of less than 6%. And in the Society of Vascular Surgery guidelines, again, the same year, 3 of the guidelines came out in the same year. Patients with who present with fixed neurologic deficit of more than 6 hours duration should be considered for carotid endarterectomy once their condition has been stabilized, and CEA should be performed within 2 weeks. So all of these guidelines are all consistent with each other of the neurologic event. And patients who present with repetitive or crescendo type of TIA unresponsive to antiplatelet therapy should be considered for urgent carotid endarterectomy. And the risk for intervention is increased over elective surgery for neurologic symptoms, but not as much as for patients with stroke in evolution. And they added carotid endarterectomy is preferred to carotid artery stenting in this patient based on the presumptive increased embolic potential of bifurcation plaque in this clinical situation. So this study, which was actually published in 2017, early this year, showed actually the temporal progression of adherence to these guidelines. As you can see, from 2005 all the way to 2013, there's a gradual decrease in the number of days between the index event and when they performed carotid endarterectomy. There's a gradual decrease in terms of the duration. No? So they were trying to adhere to the guidelines. So initially from more than 20 days, as you can see, as you go down to 2013, it also goes down within 1 week period. And likewise, patients who underwent revascularization within 14 days, there's a steady increase in adherence to these guidelines as temporarily from 2005 to 2013. Now with the 2014 AHA Stroke Council guidelines, again, not much has changed. No? When revascularization is indicated for patients with TIA or minor non-disabling stroke, it is reasonable to perform procedure within 2 weeks of the index event rather than delaying the surgery if there are no contraindications to early revascularization. Again, carotid artery stenting is indicated as an alternative to endarterectomy for these patients who have low risk or average risk for complications associated with endovascular intervention, especially with the diameter of your internal carotid artery reduced by more than 70% by non-invasive imaging or more than 50% by catheter-based imaging. And then it goes further on to say, reasonable to consider patient's age in choosing between CAS and CEA. For older patients, more than 70 years of age, it seems based on available data, carotid endarterectomy appears to have a better outcome compared to carotid artery stenting, particularly when arterial anatomy is unfavorable for endovascular intervention. But for young patients, carotid artery stenting is equivalent to carotid endarterectomy in terms of risk for peri-procedural complications such as stroke, MI, or death, and long-term risk for ipsilateral stroke. And among patients with symptomatic severe stenosis, more than 70%, in whom anatomic or medical conditions are present that greatly increase the risk of surgery, or when other specific circumstances exist, such as your radiation-induced stenosis or restenosis after CA, meaning all this adverse neck anatomy, then carotid artery stenting is reasonable. And finally, of course, stenting and carotid endarterectomy should be performed by operators with established peri-procedural stroke and mortality rates of less than 6%. On this paper, actually basically summarizes the available evidence for early carotid intervention and is apparently the basis of the most recent guidelines that I was able to dig up from the Royal College of Physicians National Guidelines for Carotid Intervention. No? So basically this paper assesses the evidence of peri-procedural or risk of carotid intervention in relating to the timing of procedure in patients with recent symptomatic carotid stenosis. So it basically reviewed studies published in the past 8 years reporting periprocedural stroke or death after carotid endarterectomy and carotid artery stenting. And they pulled estimates of this periprocedural risk and stratified them to either from 0 to 48 hours of intervention, 0 to 7 days, and 0 to 15 days. No? So this data, which I'll just summarize, but just look at the values here. For example, for CA done within 2 weeks, perioperative stroke risk is about 3.36%. And compare that with carotid endarterectomy done 0 to 7 days or within 1 week, it's almost the same, 3.25. So there's not much difference in doing carotid endarterectomy either on the 2nd week or within 1st week post-stroke. But if you do the carotid endarterectomy in, let's say, the first 48-hour period, of course, there's an increased risk of stroke, which is pegged at about 5.3%. Likewise, for carotid artery stenting, it appears that whether you do it in 2 weeks or within 1 week's time, the risk for periprocedural stroke appears to be increased. No? If you look at this, it's overall 4.7 or almost 5%, as well as for the 1 week is almost 4.76%. And if you do them in acutely, it is 2%. So, summarizing all this, current carotid surgery performed within 2 weeks or to 7 days from symptoms onset can result basically in less than 3.5% periprocedural stroke and 4% periprocedural stroke or death risk. No? And early carotid endarterectomy within the first 2 days of the index event is relatively safe with a periprocedural stroke risk of 2.7%. However, this may be associated with a higher periprocedural stroke risk of about 8% when neurologic instability in the first hours after cerebral ischemia. And then stenting, if you do them whether in 2 weeks or in 1 week, may produce a stroke risk of 4.8%, which is higher than doing an open surgery. I'll just skip this. So finally, this is the last guideline that I was able to dig up, 2016 Royal College of Physicians National Clinical Guideline for Stroke. And again, not much difference except that they are now recommending carotid endarterectomy to be performed as soon as possible within 7 days instead of the usual 2 week period. No? And they're saying the carotid endarterectomy is a treatment of choice, particularly for those people who are 70 years of age and over, and for whom intervention is planned within 7 days of stroke or TIA. And they are recommending that you do this procedure for those patients who are neurologically stable and who are fit to undergo surgery. And you would want to defer this procedure for 72 hours if the patient has received intravenous thrombolysis on the outset. No? I'll skip this. And skip this. So went on to say about carotid angioplasty and stenting should also be considered for people with symptomatic carotid stenosis, especially if you have a hostile neck anatomy, as well as for those patients who have less than 70 years of age and who have a preference for carotid artery stenting. So I'll just skip. This is basically just to justify the carotid artery stenting. And so the conclusion is, based on the current existing guidelines, it seems like carotid endarterectomy is the procedure of choice for revascularization of recent symptomatic severe extracranial carotid disease of 50% to 99% based on the NASET way of determining the stenosis, and should be performed as soon as possible within at least 7 to 14 days from the index event. Finally, carotid artery stenting may be considered in situations where patients are found to be unsuitable for open surgery or who are less than 70 years of age. Thank you.
Okay, thank you, Dr. Tuazon, for that enlightening lecture. For our fourth speaker, she will talk about the late-breaking trial, the EINSTEIN choice, Rivaroxaban versus Aspirin for extended treatment of venous thromboembolism. She had her clinical research fellowship in peripheral vascular medicine at the Philippine Heart Center. She's the head presently of the vascular unit of the Manila Doctors Hospital and a member of the training committee fellowship in cardiology section of Cardiology Manila Doctors Hospital. I'm pleased to present to you Dr. Elaine Alajar.
Thank you, Norjay, for that kind introduction. I'm just given 10 minutes actually to present the trial. Good morning, colleagues, and I'd like to thank the PHA for inviting me to speak on this particular topic. Also for Dr. Abola, who is currently out of the country, for allowing me to present the trial on her behalf since she's one of the principal investigators in the Philippines, and for Bayer for allowing me to use some of the slides that were presented in the ACC last March. So these are my disclosures. Oh, sorry. And this will be my topic outline. So VTE is the most common cause of vascular death after MI and stroke, and the mainstay of treatment is still anticoagulation, initiated either parenterally during the first 5 days, and for Rivaroxaban, during the first 21 days will be 15 milligrams twice a day, and for the first 7 days, Apixaban 10 milligrams twice a day. This will be followed by an early maintenance phase for 3 months, except those with cancer-associated thrombosis who will require low molecular weight heparin therapy during this time period. Recurrence rates after unprovoked venous thromboembolism after anticoagulation is usually around 20 to 30% and is fatal in 12%. Hence, extending anticoagulation in these patients has been suggested. However, this must be weighed against the bleeding risk in a certain patient. And attempts to reduce the risk of bleeding will be to lower the therapeutic INR to around 1.5 to 2, use aspirin instead of an anticoagulant, or use sulodexide, which is based on a recently published trial. The most recent ACCP guidelines recommend 3 months treatment in provoked proximal and distal deep vein thrombosis, pulmonary embolism, and unprovoked VTE. But in those with low bleeding risk, cancer-associated thrombosis, and unprovoked VTE, extended anticoagulation is recommended with no actual or scheduled stop date. FAMI and colleagues identified risk factors for recurrence, including patients with unprovoked proximal DVT, male gender, elevated D-dimer levels after treatment discontinuation, residual thrombosis on duplex scan, and thrombophilic disorders, including obesity. Increasing age and pulmonary embolism as the index event were also identified by Agnelli as factors for VTE recurrence. And in another study by Palaretti, they also found pregnancy, hormonal treatment, and presence of an IVC filter as factors for recurrence. Trials on anticoagulation and aspirin for extended treatment have shown significant relative risk reduction in VTE recurrence. In the PREVENT trial using warfarin to target an INR of 1.5 to 2, there was a 64% reduction. In the Warfaza trial, which combined warfarin and aspirin, there was a 41% reduction. Although no significant reduction was seen in Aspire, there was actually a significant reduction in the secondary composite of VTE, MI, stroke, and cardiovascular death, mainly driven by the reduction in arterial thromboembolic events. However, combination of these two trials in the INSPIRE resulted in a 42% risk reduction on venous thromboembolism. Using your newer oral anticoagulants in the EINSTEIN extension, Amplify extension, and Resonate trials with Rivaroxaban, Apixaban, and dabigatran respectively significantly reduced VTE risk. In this meta-analysis of 6,000 patients evaluating studies on vitamin K antagonists, the direct oral anticoagulants, and antiplatelets such as aspirin, there was a significant reduction in recurrent venous thromboembolism. However, these studies were heterogeneous in terms of the duration of initial anticoagulation, the duration of extended anticoagulation, and population characteristics. But if you look at the forest plot, the benefit was consistent in all the studies. Another primary outcome of this meta-analysis was major bleeding. Although there was a trend towards an increased risk of major bleeding using your active treatment, this did not reach statistical significance. Sulodexide, a glycosaminoglycan, was compared to placebo in the SURVET trial, and after 2 years of giving the drug, there was a significant reduction of VTE recurrence. After adjusting for confounders, there was still a significant reduction in the primary outcome with no major bleeding reported. The reduction in recurrent VTE based on this trial, however, was mainly driven by the significant reduction in DVT alone and not by pulmonary embolism. So during the ACC convention last March, the EINSTEIN choice was presented as a late-breaking trial. And this trial compared the efficacy and safety of either 20 milligrams of Rivaroxaban, 10 milligrams of Rivaroxaban, or 100 milligrams of aspirin given for 12 months in VTE patients who have completed at least 6 to 12 months of anticoagulation. So why the 3 treatment arms? In the EINSTEIN extension, Rivaroxaban reduced recurrent VTE by 82% compared to placebo with similar major bleeding risk. In the record trial, 10 milligrams of Rivaroxaban was shown to be effective in VTE prevention after total hip or knee arthroplasty. And as discussed earlier, aspirin reduced VTE recurrence by around 30% without increased major bleeding. They included patients who had objectively confirmed symptomatic VTE, treated for 6 to 12 months with an anticoagulant, and the therapy should not be interrupted for more than 7 days prior to randomization. These were the exclusion criteria. And the primary efficacy outcome was a reduction in recurrent VTE, while the primary safety outcome was an increase in major bleeding. There were 244 sites in 31 countries who participated in enrolling more than 3,000 patients into the trial. And the Philippines was one of the Asian countries who participated, with Philippine Heart Center as the site. Based on the clinical characteristics, there was no difference in the population. 55% were male, and less than 5% had a GFR of less than 50 mils per minute. Majority had DVT as an index event, with both provoked and unprovoked VTE represented. So most trials usually included unprovoked VTE. Primary efficacy outcome event occurred in 1.5% with a 20 milligram dose, 1.2% with a 10 milligram dose, and 4.4% with aspirin, translating into superior reduction in the rates of recurrent VTE with both doses of Rivaroxaban compared to aspirin. When each of the components of the primary outcome were analyzed, DVT and PE were significantly reduced with both doses of Rivaroxaban compared to aspirin. Other efficacy endpoints, including total mortality, were also significantly reduced with either Rivaroxaban dose compared with aspirin. On subgroup analysis, regardless of gender, age, body weight, and body mass index, the 20 milligram dose reduced symptomatic recurrent fatal or non-fatal VTE compared to aspirin. And this reduction was consistent regardless of the type and extent of index event and a previous history of recurrent VTE. The outcome reduction with a 20 milligram dose was also observed in both provoked and unprovoked VTE. Similar results were seen with the 10 milligram dose as compared to that of the 20 milligram dose. And even with a lower dose, there was a significant reduction in outcome regardless of the type and extent of index event, history of recurrent VTE as compared with aspirin. Regardless of whether the VTE was provoked or unprovoked, there was a significant reduction using the 10 milligram dose of Rivaroxaban. In terms of the primary safety outcome, major bleeding rates were less than 0.5% in all treatment arms, with major bleeding rates with both doses of Rivaroxaban similar to that of aspirin. On analysis of the various bleeding outcomes, there was no significant difference between Rivaroxaban and aspirin. So what are the clinical implications of this particular trial? Rivaroxaban, based on the Einstein choice, reduced the relative risk of recurrence by 70% in both unprovoked and provoked VTE. So 33 patients need to be treated with 20 milligrams of Rivaroxaban and 30 patients with 10 milligrams of Rivaroxaban instead of aspirin for 12 months to prevent one fatal or non-fatal recurrent VTE without increasing the risk of bleeding. But there are some study limitations. First, patients who require extended treatment with therapeutic doses of anticoagulants were excluded, so we're not really sure if the 10 milligram dose of Rivaroxaban is sufficient to prevent the recurrence in such patients. The treatment was given for only 12 months, so additional studies may need to be done to determine the utility of continuing treatment for longer periods. And the study was not powered to show non-inferiority of the 10 milligram dose to that of the 20 milligram dose of Rivaroxaban. So in summary, despite therapeutic anticoagulation of VTE, the risk for recurrence remains increased once anticoagulation is discontinued by about 20 to 30%. Aspirin, vitamin K antagonist, your direct oral anticoagulants reduce VTE recurrence. Sulodexide on the Servet trial reduced DVT recurrence. However, when choosing whether to treat the patient or not, bleeding risk must always be considered. And in the Einstein choice, Rivaroxaban at 20 milligrams and 10 milligrams reduced symptomatic, recurrent, fatal, or non-fatal VTE with no increase in major bleeding compared with aspirin. With a caveat that currently in the Philippines, the FDA has not yet approved the 10 milligram Rivaroxaban dose for the extended treatment of VTE. Thank you.
Thank you very much, Dr. Alajar, for a very informative lecture. With the interest of time, in behalf of the Philippine Heart Association, we would like to thank all those who attended these early lectures, and also especially to the speakers. So we forego with the question and answer because we have the next session, and our speakers are very much willing to answer your questions personally. You may approach, they are willing to be approached for specific questions, not personal questions. So thank you very much for coming.